afternoon, everyone. Thank you so much for the invitation, Lynn, to be here and to the program organizers. My name is Laurie McKenzie. I'm a fertility specialist, and you may be asking, why is a fertility specialist here talking to us at this conference? But this is an area of great interest to me and hopefully of great interest to you. And hopefully by the end of this very brief talk, you'll have an understanding of why I'm here today. So what I'm going to be doing first is defining what is the field of oncofertility. That may not even be a word that you're familiar with. And hopefully over these next few minutes, it's something that you'll certainly be much more familiar with and understand the rationale for why I'm speaking with you today. I'm going to talk about briefly how to obtain a fertility assessment and how to track fertility treatment or fertility during treatment and also following completion of treatment. What are some fertility preservation options that should be considered before you start treatment for desmoid tumors? And also very briefly touch on some of the reproductive considerations with gamma secretase inhibitors. And I'll be brief in terms of the slides because I really want to make sure that I'm addressing clinical questions that you have, and we'll leave a few clinical considerations at the end. So what is oncofertility? Oncofertility is a subspecialty of medicine to really bridge oncology and reproductive medicine to expand family building options for those affected by cancer therapies or therapies that may negatively impact fertility. And so if we look at individuals specifically that are affected by desmoid tumors, this is primarily a reproductive aged population with a female predominance. So a lot of what I'll be focusing on the slides are female oriented, but certainly there are men that are impacted with desmoid tumors, and I'll touch briefly too on some of the fertility preservation options for men. So when I meet with a patient that has a new diagnosis of desmoid tumors, my recommendation is to get a baseline fertility assessment. And there are multiple clinical variables that will impact what is somebody's baseline fertility going into treatment. So it can be the age of the patient, what is her or his specific reproductive history. For female patients, what is their menstrual status, and what is their baseline ovarian reserve. And that may not be a term that you're familiar with, but it's an important one. And basically, it's the ability to assess what is going on in terms of ovarian function in a woman, okay? And there are two objective measures that we use most commonly to evaluate ovarian reserve. So this is a reflection of the resting number of eggs in the oocytes and is reflected by a blood test called an AMH, anti-Müllerian hormone. This is a hormone that's produced from cells that surround and support the egg. So these granulosa cells that produce anti-Müllerian hormone will give us a very good idea of what is somebody's ovarian function and the number of eggs that they have. So the higher the AMH, the higher the number of eggs that individual has. Okay, so that's a nice, easy metric. It's a blood test that you can do to determine, one aspect of ovarian reserve. The other test is an ultrasound. It's a vaginal ultrasound where you look at the ovaries and you actually count the resting number of eggs or follicles that you see on each of the ovaries. And that's called an AFC, or antral follicle count. And so I would really encourage anyone that is considering start of systemic therapy to think about meeting with your physician, talking about, what could be the potential reproductive impacts. And if these tests haven't been obtained prior to initiation of therapy, to consider getting these tests before you start treatment. And another consideration for a lot of patients is to talk about and this is true not just for gamma secretase inhibitors, but other just systemic therapy. So I work over at MD Anderson, and so this is a conversation that I'm having very commonly with patients to talk about, if they're getting ready to start treatment with drugs that we know have a negative effect on fertility, should we be thinking about ways to try to protect fertility for the future? And what are some of these fertility preservation options? And the most common are gamete cryopreservation, so cryopreserving sperm, cryopreserving eggs, embryos, or ovarian tissue before you start treatment. So that way, if there is some negative consequences in terms of your treatment, that you would have this as another option in terms of future family building. And these options are have been around for quite some time. I don't think a lot of individuals realize, but sperm freezing has been around since 1953. Egg and embryo banking have been performed for a long period of time, and the most recent is ovarian tissue freezing. So that is where you would actually remove an ovary or strips of the ovarian cortex or the shell of the ovary to cryopreserve that tissue to then retransplant that tissue into a patient years later after completion of therapy. And so a question I get frequently is, well, what's involved with freezing eggs? So if you have a reproductive aged woman that's interested in cryopreserving eggs or embryos before starting treatment, that process typically takes about 2 to 3 weeks. So it doesn't help me much if I'm getting referred a patient the day that they're supposed to start treatment. I really need that 2 to 3 week window in order to facilitate egg harvest. And the reason for that is because normally a woman produces 1 mature egg a month. And I'm greedy as far as eggs go. I want a lot of eggs to be recovered and cryopreserved. So in order to facilitate that, fertility injections have to be utilized. These are recombinant hormones. These are hormones FSH and LH that are normally produced by the pituitary gland that a patient self-administers for about a week and a half to stimulate or recruit multiple eggs to grow. And then when those eggs are ready, and we know this based on transvaginal ultrasound, we then schedule the egg harvest, which is a vaginal procedure that takes about 30 minutes and is done under conscious sedation. So it's not any abdominal procedure. It's tolerated quite well. It's an outpatient procedure, and typically you leave the clinic about 2 to 3 hours after the procedure. But it does take some time. Now, in terms of semen analysis and sperm cryopreservation, this is another important option to discuss with our male patients. And there are many sperm banks throughout the U.S. Most patients in the U.S. will have pretty easy access to sperm banking. And many cancer programs have collaborations or relationships with the local sperm banks where they will allow for reduced cost sperm banking. For example, we have a partnership with Fairfax Cryobank here in Houston that will provide low cost or no cost sperm banking for patients that need it. The important take-home clinical points in terms of sperm banking is it's really important to ask the banking center for a copy of the banking report and to keep that information in a protected place where your important documents are kept at home. Several times a year, I receive a call from someone saying, I have eggs or I have sperm somewhere in Houston and I don't know where they are and I want to use them. And so I think keeping a copy of that information is really important, but it also will have the information in terms of what were those sperm parameters. Was the sperm quality good? How many vials of sperm was obtained and cryopreserved? And what option would be needed for future pregnancy if somebody needed to use that cryopreserved sperm? And the same thing goes with eggs and embryos. How many eggs were cryopreserved? How many embryos were banked? And what are the quality of those gametes? And this is something I really would like to highlight. You know, last fall, just before nirogacestat was approved by the FDA, just 1 month earlier, ASCO, the American Society for Clinical Oncology, came out with a committee statement. And I think it's important enough that I really want to share this with you today. And they're really advocating for assessment of ovarian toxicity for any new and developing drugs that could affect reproductive aged individuals. Okay, their statement was specific to ovarian toxicity, so this was directed towards female patients. I expect there's going to be a similar statement coming out soon in terms of male patients. but they really advocated for measurement of ovarian toxicity at a minimum at baseline and at 12 to 24 months after their treatment completion, and to assess clinical measures like menstrual cycles, for example, as well as biomarkers of ovarian function. So those two tests that I mentioned, the AMH and the antral follicle count, are recommended in this guideline. And ASCO had asserted that this issue is of such importance, it cannot continue to be overlooked. And if you notice, there's such a lack of reproductive data with so many different therapeutics that are out there. So I really applaud ASCO for coming out with this statement. And I have to say, just a shout out to SpringWorks for taking the initiative to collect some of this data, even predating this ASCO guideline. And so we have some ovarian assessments in terms of their recent product launch. So a couple notes, and I'm not going to go into a lot of detail unless this is something that you want to open up in terms of questions. But I think just a couple points in terms of nirogacestat is just the importance of reliable contraception during treatment and for at least 1 week after completion of therapy. And this is true for both men and women. And there does seem to be some adverse effects in terms of reproductive function for women that are taking nirogacestat, but it does fortunately seem to be transient, with the vast majority of women recovering ovarian function after, even while they're on drug. And for the study population, and this was published last May in Cancer, anybody that had any of the female reproductive aged individuals that had taken this drug after they completed therapy all had recovery of the ovarian markers that were assessed in this study. So that was quite reassuring to me in terms of this, in terms of their ovarian toxicity assessments. And so some things that I would advocate for you to discuss with your clinical team, if you're thinking of getting started on any type of systemic therapy, to ask, what is the anticipated duration of therapy? How are you going to track my reproductive function before and after treatment? Are we going to be doing ovarian reserve testing? And if not, why? Because I would really argue that this would make a lot of sense to obtain before starting therapy and then to have a comparator, certainly at a minimum when you complete therapy. And what are some options in terms of fertility preservation? Is egg freezing, embryo banking, sperm banking an option? And if not, why? And is this something that you want to be proactive about pursuing before you embark on systemic therapy? And if you do want to do fertility preservation, what are the options financially that will help in terms of coverage in your state? And this varies very much state by state, depends on the insurance carrier. So we see quite a bit of differences throughout. And there's a really good resource through the fertilityalliance.org, which tracks which states offer mandated fertility coverage or not. So it's a really good resource. And then what is the impact of pregnancy if somebody was to get pregnant on treatment, or is there a time frame that somebody should wait post-treatment completion? So those are kind of the take-home points I would like to leave you with, and certainly would like to open it up for questions, being mindful of time. And so again, thank you for the invitation and allowing me to really just reinforce what I think is such an important aspect related to survivorship care, and that's reproductive capacity. So thanks again for your attention. Mhm. And while we're waiting for questions, Fertility Alliance is a really good resource. There's also a good resource, the Oncofertility Consortium.org, which is based, was at Northwestern and is now at University of Michigan, is another really good resource for online information related to reproductive toxicities of various systemic therapies. Mhm. Is this something that are most of you familiar in terms of reproductive considerations or baseline fertility testing, or is this fairly new information? I'm just kind of curious. For anybody that's started treatment, were these conversations held at all before starting therapy? And I see a lot of no's. Yeah. So we really want to change that. Okay. Um, yes. A great question. Yeah. Mhm. Absolutely. Yes, thank you for asking that. It's a great question. So the question was, should we have concerns for that week and a half that somebody is on fertility treatment to try to stimulate egg production? Should we worry in terms of those medications increasing estrogen levels? And you're right, those fertility medications will typically increase the estrogen levels significantly for those 8 to 12 days that you're on the fertility medications. So for anybody that has a potentially hormonally sensitive tumor, whether it's desmoid tumors, breast cancer, low-grade ovarian serous tumors, we want to keep those estrogen levels low during therapy. And so if you're on those fertility injections, you can actually take a pill called letrozole. It's an aromatase inhibitor that keeps the estrogen level much more physiologic. So for patients, for example, that I'm doing egg freezing with breast cancer, that's considered standard of care. And it's important to communicate with the fertility physician that you're working with that, look, we want to keep the estrogen levels low, because they may not be thinking about that in the context of a desmoid tumor. So there's still a lot of education that's needed, even among the reproductive endocrinologists, to keep the estrogen levels low. So letrozole does not inhibit the recruitment of eggs, but it markedly keeps the estrogen levels low. Yeah. So thank you for that question. Yeah. Yes, please.
Is it just standard practice that they issue a report back to the patient regarding the quality of the eggs preserved and the number of preserved?
They should. Yes, they should give you information. Typically, what we do is we schedule a follow up 2 weeks after egg harvest, and we give the information. Here's where your oocytes are stored. Here's how many eggs you have. Here's how many are mature. When you cryopreserve eggs, you can't tell a whole lot about the quality of the eggs. It's more just binary. Either it's mature or immature. Now, when embryos are banked, so after the eggs are fertilized and they're grown for 5 days, there's a lot more assessments you can make on the embryo to say, does that embryo have a high chance to lead to a pregnancy or not? Unfortunately, with oocytes or eggs, you really only can get the data in terms of is it mature or not. You don't have a lot of information about how likely are those eggs going to work down the line, other than just the age of the patient at the time that they're frozen. Yeah, so for a 35-year-old, somewhere 12 to 14 would be a typical number. If that kind of, and if you're younger, you would expect a few more. If you're older, you would expect fewer. And so if I have somebody after age 43, we typically don't recommend egg freezing, just because the likelihood of getting multiple good quality eggs would be low. hmm hmm hmm
Like you said, it's out there, out the place, but I don't know anything further.
Right. And until they're thawed, you probably won't have a lot of information other than just the numbers. hmm Yeah, great question. Yes.
How should we think about reproductive health for pediatric patients where it doesn't feel as relevant yet, but at the same time, kind of thinking to the future? How do you coach patients or caregivers in that regard? And then also, there's long-term kind of components to treatment and how that might impact future
Yeah,
reproduction.
it's challenging if they're prepubertal. Certainly, I care about those patients just the same as I would my postpubertal patients. And in fact, you might say even more so, because they have a longer, time in terms of their reproductive considerations. But we're much more limited in terms of what we can offer. If somebody hasn't gone into puberty yet, you can't stimulate mature oocytes. And then the question is, do you put them through ovarian tissue freezing where you're actually removing an ovary? It depends on what the indication would be for. Like, I would argue for gamma secretase inhibitor therapy, no, I would not want, because the data so far is overall quite reassuring once completion of therapy that these patients will have recovery of ovarian function. I wouldn't want to put somebody through a surgical procedure to remove an ovary to allow for ovarian tissue freezing. But I think tracking their fertility is still very important. So even for those younger patients, I won't order antral follicle count assessments because I don't want them going through a transvaginal ultrasound, but certainly I track their AMH and their hormone values as well. Mhm. Yeah, sure. Yeah, well, thanks again for your time. Thanks for having me here. And I hope you enjoy the rest of your afternoon. Thanks for your questions. Sure.